Hello, everyone. This is RF, and welcome to Offbeat Medicine. Let's start with leukemias. So, the first thing, what do we have? We have the unregulated growth and differentiation of WBCs in bone marrow. There's unregulated growth, which has differentiation of WBCs where in the bone marrow. From the bone marrow, it leads to marrow failure, leads to anemia, which is decreased RBCs, infections due to decreased WBCs, and hemorrhage due to decrease in platelets. So basically, pancytopenias. Okay, usually presents with increase in circulating WBCs, which is malignant leukocytes. Which WBCs are these? They are the unregulated growth of WBCs. They are malignant leukocytes in blood. Although some cases it presents with decrease or normal WBCs. But remember, we will have infections because the mature WBCs or normal WBCs are not there. These WBCs are unregulated growth or malignant WBCs. So let's talk about leukemic cell infiltration will occur in the liver, the spleen, lymph nodes, and skin. When it occurs in the skin, it's called leukemia cutis, which is also possible. So before we move on and talk about all of this, the types, let's just little bit illustrate what about acute and chronic leukemias. So if you were to talk about acute leukemias, we have neoplastic proliferation of cells greater than 20% of blasts seen in the bone marrow. So neoplastic proliferation of more than 20% of the blast in bone marrow. So that's going to crowd your bone marrow. When you crowd the bone marrow, that is going to decrease all hematopoiesis, leading to pancytopenia. All three cell lines are going to decrease. Okay, that's the acute. Now let's talk about the chronic. If you have chronic leukemia, what's going to happen is you have, again, same thing, you have the neoplastic proliferation of, now here in the chronic one, you have the mature lymphocytes. So you have the neoplastic proliferation of mature lymphocytes. Mature lymphocytes. And also mature granulocytes. So let me just do it here. Mature lymphocytes and mature meaning they're when they're in the blood. When they're in the blood, they're mature. Sorry. So those mature lymphocytes and mature granulocytes. And this is all chronic leukemias. And if you were to differentiate them, what are the lymphocytes? So in the lymphocytes, we have the B cells and the T cells. So either we will have naive B cell lymphoma. That's going to be called CLL, chronic lymphocytic leukemia. You can have mature B cell leukemia. That's going to be called hairy cell leukemia. Now, enough of the B cell. Now let's talk about the T cells, right? So if you have the mature T cell, which one? CD4 positive T cells, you can form two things: ATLL and mycosis fungoides. We talked about it in the previous section, but we will also go through it together today. So these are the chronic leukemias. So this is just a background information. Now let's talk about lymphoid. The types, we have the lymphoid, neoplasms, and we have the myeloid neoplasms. So lymphoid, let's talk about the first one we have is the ALL, acute lymphoblastic leukemia lymphoma. It is most frequently occur in children and less common in adults. If it was to happen, then it's going to have worse prognosis. T cell ALL can present at mediastinal mass, presenting in a superior vena cava-like syndrome. Associated with Down syndrome, peripheral blood and bone marrow have increased lymphoblast. It's a lymphoid neoplasm, increase in lymphoblast. That's pretty simple to know. But looking at picture A, let's look at that. We have the blast cells. These are the blast cell, known as lymphoblast. And how do we know they're bigger than the normal? Because they're blast. How? Because normally the lymphocyte has a size of something like an RBC size. The nucleus of the lymphocyte has the size of an RBC, but here it's way bigger. That's a blast. Lymphoblast, these are large cells, one thing. And second thing, they have less cytoplasm than normal. Less cytoplasm. One thing, they're large. Second thing is they have less cytoplasm. And there could be presence of punched out nucleoli. There could be plus minus. Could be, could not be. Punched out nucleoli in these blast cells. Okay. So that's the increase in lymphoblasts. They have in ALL you have the very important TDT positive. Okay, they are TED positive, which is a marker of pre-T and pre-B cells. So what do we mean by pre-T? Meaning blast. We're again talking about blast here. Again mentioning they're TDT positive because they're blast cells. So all blasts would have TDT positive. And CD10 positive, marker of pre-B cells. So marker of pre-B cells is the CD10. Their response to therapy, that's a good thing, may spread to the CNS and testes. Okay. So the treatment would be, if they go into the CNS and testes, you would have to directly inject the chemotherapy into these organs. Okay, now let's talk about their translocation 1221 translocation, which has a better prognosis than the Philadelphia chromosome, which is 9022 translocation, which has the worse prognosis. And this is seen as we mentioned, that this is more in adults as a worse prognosis. Okay, so that's pretty much for the ALL. And what are the important points here? That it is common in children, not much seen in adults, but if it's seen, it has a worse prognosis. How does it present? It presents as a mediastinal mass, just like superior vena cava syndrome-like syndrome, superior vena cava-like syndrome. It is sort of it down. You will see increase in blast, very important. Increase in lymphoblast, TDT positive cells, CD10 positive cells, if they are pre-Bs. But what about if they're T's? Well, they haven't mentioned here, but you can just think that if they have the way I think about it, if the CD10, if it is less than CD10, then always think that it is T cell origin. All the T cells have less than CD10. What do I mean by less than CD10? Meaning, T cells have CD1, CD3 to 8, CD1, CD2, and CD3, and CD4, 5, 6, 7, 8. So they have these CD markers for the T cells. For the B cells, you have CD10, you have CD19, you have CD20, which is also very important for B cells, and CD23. So the way I think about it is greater than 10 is associated with B cells. Less than 10, this is just surface markers, okay? We are looking for T cells. So if they were to mention, okay, CD1 is positive, then I'm now going to think about B cell, I'm going to think about T cell, and call it T cell ALL. T cell ALL. And if it is a B cell, CDB, more than CD10, greater than 10, or then I will call it B cell ALL. If you don't want to remember that, that's fine. That's an extra tangent. But whatever the first it has, that is pretty good to remember if you can. Okay, so that's all about ALL. Let's talk about now CLL, chronic lymphocytic leukemia, other name small lymphocytic lymphoma. Okay, so this is chronic, seen in greater or than 60 years of age, most common in adult leukemia. Now, CD20 positive, 23 positive, CD5 positive B cell neoplasm. Okay, so what is the CD5? These are basically naive. CD5 means naive cells. Naive cells. Lymphocytes. Okay. Then you have often asymptomatic. Now this thing is asymptomatic. It has a progression which is slowly. Smudge cells are seen in the peripheral blood smear, which is shown in the picture B. Let's look at smudge cells. These are the smudge cells. And look, increase in lymphocytes as well. Smudge cells. Smudge cells. Okay, an autoimmune hemolytic anemia. CLL, crushed little lymphocyte, smudge cell. That's a good one actually. Crushed the little lymphocyte makes the formation of smudge cell. Just to remember it. Okay, then you have the Richter transformation, which is CLL-SL, which is SL means small lymphocytic lymphoma. Transformation into, what is this transformation? When the CLL transforms into aggressive lymphoma, most commonly diffuse large B cell lymphoma. So this can go into diffuse large B cell lymphoma through the Richter transformation. Okay, so although they said it is often asymptomatic, but how is it going to present with no symptoms? So again, you have the same. If you look up top, you have pancytopenia, patient with pancytopenia, but increase in WBCs. Okay, lymphadenopathies, hepatosplenomegaly. Okay, with this hemolytic anemia, and you have hypogammaglobulinemia, gamma globulinemia, that leads to infections. And it is a B cell neoplasm. It is a B cell neoplasm. And when it transforms into this large B cell lymphoma, this is just going to change into enlargement or enlarging that lymphadenopathy, lymph nodes, and hepatosplenomegaly. That the patient already had this, but on top of this, now they're enlarging more. So, why this happened? It happened because of there's an overexpression of BCL2. So what's the treatment? Treatment is to inhibit that BCL2. What's that drug? That is called venetoclax. Venetoclax. That inhibits the BCL2. And that's the treatment. Alright, moving on with the hairy cell leukemia. Hairy cell leukemia, we also see them in adult males. So from children to higher age, now to adults. It's a mature B cell tumor. Here we said it's a B cell neoplasm, but remember it's both naive B cell, as we mentioned, CD5 is naive for naive cells, and also mature B cells, because all of this is for mature B cells. Okay, and here we're just mentioning that, okay, you have mature B cell tumor. Cells have filamentous, hairy-like projections, fussy appearance on light microscopy. Look at picture C. Cells have hairy projections and filamentous. You can see some filaments. I don't know if you can. Let me try to zoom in, show you. You can see some filaments, like something is going on. Some eruptions or something is going on inside them. Filaments. And what else? Filamentous, hairy, hair-like projections, and you will have peripheral lymphadenopathies uncommon, so you do not see any lymphadenopathy here. Causes, this would cause marrow fibrosis. When the marrow is fibrosed, you were to do bone marrow biopsy, there's a dry tap on aspiration because there's fibrosis of the marrow, so there's a dry tap. Patient usually presents with massive splenomegaly and pancytopenia. So differentiating this adult versus this adult, here you have lymphadenopathy. Here you don't have any lymphadenopathy. And most importantly, look at the cells. We see these cells, filamentous, hairy-like projection cells. Okay, that's another important. And stain is also important. We're going to talk about that. It stains TRAP, which is a tar-trait-resistant acid phosphatase. TRAP, tar-trait-resistant acid phosphatase, positive. Remember, they're trapped in hairy situation. You're trapped in hairy situation. Here's trap things. Okay, that's a good mnemonic. Trap stain largely replaced with flow cytometry now. Associated with BRAF mutation. Treatment is purine analogs like cladribine and pentostatin. Okay. So here, because of this dry tap again, you will have they have mentioned pancytopenia. Dry tap meaning there is no marrow, there is no bone marrow. Dry tap meaning no marrow means no cells leading to a pancytopenia. Okay. This clorbidine, it is a adenosine deaminase inhibitor. And because adenosine accumulates to toxic levels in these neoplastic B cells, this leads to death of neoplastic B cells. Okay. So what's happening is when you inhibit this leads to increase in adenosine. When increase in adenosine leads to, it is toxic to the neoplastic cells. So increase in adenosine accumulates to a toxic level in these neoplastic B cells, which leads to death of these neoplastic B cells. That's the mechanism of clodribine. Okay. Yeah, that's pretty much what we have for the lymphoid neoplasm. So let's move on with the myeloid lymphoplasms. Myeloid lymphoplasms, we have AML, acute myelogenous leukemia. The median onset, again, you can just think is old adult. 65 years is the median onset. You have very important R rods are there. Looking at D picture, we have the R rods. What are the R rods? Look at this. I mean, this picture here, R rods. These are R rods. R rods. They are, but nobody's gonna say R rods, right? Or maybe some question they do, but it's a purple red inclusions within myeloblasts. So purple red inclusion in the myeloblasts. Purple red inclusion in the myeloblasts. Very large. So looking at the cell itself, they are very large nucleated cell as compared with RBC, with scanty cytoplasm. So we have very low sparse cytoplasm, but very large nucleus. And going back to the R rod up top, so R rod, and then you have this myeloperoxidase positive cytoplasmic inclusions. So these are rod, as I mentioned, they are the purple red inclusions, right? Purple red inclusions, as seen there. So these are rods. They form crystal aggregates. Segregation occurs of these, let's say, crystals. So where do these rods come from? That's the question that I'm trying to answer. So they are coming from, these are crystal aggregates of MPO. What is MPO? Myeloperoxidase. So myeloperoxidase forms the R rods. So myeloperoxidase positive, R rod positive. Okay, in the myeloid neoplasm AML. Then we have They can also say for all rods, they would be mentioning needle rod shaped. Needle/rod shaped. As you can see, they're needle rod shaped inclusions, right? Are mostly seen in, this is mostly seen in APL, which is former, and 3ML. Okay. Increase in circulating myeloblast on peripheral smear. On peripheral smear. And increase in circulating immature myeloid cells. When they say myeloblast, they're the immature myeloid cells. The other name they can say is promyelocytes. Promyelocytes are circulating in the blood. Promyelocytes, which will also contain our rod, right? On the peripheral blood smear. May present with leukostasis. Very important. Very important. What is leukostasis? It's a capillary occlusion by malignant non-distendable cells leading to organ damage. Okay. What are the risk factors to this AML? You have the prior exposure to alkylating chemotherapy, radiation, benzene, myeloproliferative disorders, Down syndrome, typically acute megakaryoblast leukemia, former M7 AML, APL now. There's a translocation of 15 to 17 translocation. Response to. So what is this translocation before we talk about its treatment? Well, the translocation is simple here. You have retinoic acid on chromosome 17. Okay. So when the translocation occurred from chromosome 17 to chromosome 15, this leads to RAR disruption, which blocks the maturation and accumulation of blast would follow. Okay. So I hope you get the point. I can write it down here. So on chromosome 15, so when the translocation occurred, now this translocation leads to RAR. What is RAR? Retinoic acid receptor disrupted because of it has been translocated. When RAR gets disrupted, this leads to blocking of maturation. And when you block the maturation, now you have the blasts stay with what they were. They are the blasts, so they stay. They can't mature. So accumulation of blast, also known as promyelocytes, as I mentioned already. Okay, now all you need to do is they respond to all trans retinoic acid, which is vitamin A. So what's going to happen when you give vitamin A? Because you didn't have the you had the disruption of RAR. So when you give from outside, when you give vitamin A, that matures these blasts. So vitamin A acts on them, like retinoic acid, acts on them and matures them, and they form the lymphocytes. So that's the all trans retinoic acid vitamin A works. Arsenic trioxide can work, which induce differentiation of promyelocytes. DIC is common presentation, and in DIC we did talk about as a factor is AML, or etiology of DIC in AML. Okay, And remember, this patient will be presenting with, let's say, they're saying it's a common presentation, meaning it's going to present with DIC. So a patient in DIC would have increased D dimers, increase in PTT, or decrease in fibrinogens and all the labs, right? So that's what we have here. So for this one, what's important now that you have to know, that's the MPO positive, formation of all rods, and age, and leukostasis, Down syndrome. Yeah, I think we skipped that part, or we didn't, I don't know. But Down syndrome is important. It is associated with Down syndrome in less than 5 years of age, in children of 5 years of age. Okay, and then the treatment and the translocation, DAC. Moving on with the CML, chronic myelogenous leukemia. Now, their peak incidence is 45 to 85 years. Median aging in 64. So almost similar, right? Defined by Philadelphia chromosome, which is a translocation of 922 translocation, in which you have the BCR to ABL. And myeloid stem cell proliferation presents with dysregulated production of mature and maturing granulocytes. Okay. Neutrophils, metamelanocytes, myelocytes, basophils. Look in the picture E. You have all these cells. And splenomegaly may accelerate and transform to AML or ALL, blast crisis. Response to BCR, ABL, tyrosine kinase inhibitor, imatinib. Okay. So in here, what's happening is that at this translocation, you have ABL is transported from chromosome 9 to chromosome 22, where it is placed adjacent to the BCR, right? Excuse me. That BCR ABL fusion protein stimulates the tyrosine kinase. So this is really important to know that this fusion stimulates tyrosine kinase. When you stimulate the tyrosine kinase activity, that leads to formation of which leads to proliferation of granulocyte precursors, proliferation of granulocyte precursors, which leads to formation of CML. Now all you gotta do is give tyrosine kinase inhibitor, stop this step. Give tyrosine kinase inhibitor, you have inhibited this step. There will be no proliferation, there will be no CML. Okay, so that's where the imatinib comes into the place. Okay, and let me also write here one thing, that as we said, that you have the neutrophils, metamelanocytes, myelocytes, basophils, splenomegaly. Now, you will also have increase in from these cells. You have histamine released, and that is going to cause pruritus. So the way it can be mentioned is, person takes hot shower. After the hot shower, he has pruritus. Well, after the hot shower, what really happened is basophils get stimulated, that release the histamine which caused pruritus. Okay. So, yeah, that's pretty much all you have for CML. This is very important. Philadelphia chromosome, any age. This is the Philadelphia chromosome, which is a tyrosine. Now, this fusion leads to tyrosine kinase stimulation that leads to proliferation. Imatinib inhibit the tyrosine kinase, and you're good to go. Okay, so that's pretty much all we have for the CML.